And welcome again to the lighter side. The lighter side on a very heavy topic, and we call it the lighter side because we try to add a little bit of lightness to it, a little bit of humor. Anyways, I'm Dr. Ortiz, and today we're going to talk about a really cool subject, which is basically how weight loss surgery works. And of course, when I show you these graphics, you're going to say, "What's up, man? This is like cool." So, what surgeons do inside to obtain that objective, which is how to make a stomach respond and then in turn create wellness through weight loss. So it's going to be a very cool 20 minutes. But before we go to this topic, I just want to say, like us, follow us, share this. This is especially really good because we're going to be talking about a topic. In fact, let me show you what topic we're going to be talking about, because I even put a little video on this, and it is revision surgery right for you? So anyways, revision surgery is basically fixing a surgery that had already been done, but we're going to go into the basics of surgery. We don't have an invited guest today, so I'm going to go right into our first video, and this video is going to show you a graphic representation of what the stomach looks like and what we do in surgery, but then I'm going to break it down, so don't worry if it goes a little fast right now. So let's start off with this video, and the first thing you're going to see is a stomach. That's what the stomach looks like. So in the following slides, I'm going to show you step by step where the esophagus, the intestine, stomach, and things like this. So as I play the video, you're going to see how typically when we do a weight loss surgery, we staple, and we staple to make the stomach smaller. In this case, it looks like a long sleeve. That's why it's called a gastric sleeve. And then we measure the diameter, we gauge it, and those are the diameters. And what do we gauge it with? With a bougie. That's what the bougie looks like. And how do we do this? Well, we staple across the dotted line very intimately right along. You see that blue tube. And then when we finish OCC, we do a special proprietary technique where we oversew, and then we ultimately end up with a much smaller stomach. And as we remove that inside gauging tube, we are left with the imprint of a very, very small stomach that you can then see under X-ray, as we are seeing here. And this is what happens when we do weight loss surgery. Of course, we've been doing this for 25 years, almost 25 years, 24,000 patients. And we more or less have created a scenario where we've perfected the technique. We're extremely happy with the results. And now, importantly, before I go into these images, I want to tell you I am watching my Facebook feed and all the different YouTube feeds, etc., because we are live. And ask your questions and I'm going to answer them. In fact, we have a questions and answer session immediately after this. But, I'm getting from Linda. Hello, what's up? How do you add the gas? Really, really want to know. Okay, that's really cool. I will show you in the following slides, but let's start off with these images. Now, I'm going to scribble a little bit on these images because I want you guys to see what I'm talking about. So this area is the esophagus. Now, our body is divided into two. We open it. We have the diaphragm or the chest cavity, and then a flat muscle right here that divides us. This is called the diaphragm. It's the breathing muscle. So everything from this line up is in the chest cavity, and from this line down is in the abdomen. So the stomach really lies in the abdomen, and the esophagus lies up inside the chest. When this stomach creeps up into the chest, that's what's called a hiatal hernia. The stomach shouldn't be up into the chest. And as we suck air, when we breathe, we also suck acid up into the esophagus if there's a hernia, and that's why you get Gerd. That's a cool explanation, huh? Even I'm impressed. All right, so this is what a staple line looks like. See, really small little staples. If you want to know what staples look like, look at a Bible. Read your Bible, ladies and gentlemen. Well, actually, those letters are as small as the little Bible letters, right? Because, they cram up all these verses inside. So anyways, staples are really small. And this is what a typical stapling looks like from a graphic representation. Now, remember we were talking about gauging? We always gauge. We don't want to guess right here because we're going to cut across the dotted line to make this stomach smaller. So, in fact, in order to do that, we just can't guess. This is the stapler over here. So what we do is we introduce this blue tube, which is called a calibration tube. And everybody's asking me, well, what size calibration do you do? Because I saw online that 32, 34, 36, 38, whatever. Everybody wants to tell me as a surgeon what to do. Anyways, been doing this for a while, so what we've done over the years is we've actually perfected the technique in a sense that we know exactly what type of calibration we need to do. And here it is. That's the 32 French. A dime is 50 French. So we're talking about diameters. In other words, if this 32 French was a tube, we're talking about a tube more or less the width of your index finger. And that's how we calibrate a stomach. Remember that blue tube we were talking about? So when we calibrate, we can either calibrate lower or higher. The problem is, if you go lower, you're going to cause back pressure. And I'm going to go back to these slides. These are ugly slides. Let me use this one. Anyways, if you calibrate and this area is too tight, you're going to have back pressure. And if a patient has surgery and has back pressure, what do they get, class? They get heartburn, they get reflux. But if it's too loose, like this width, what do they get? They get a half inflated stomach, which is basically a failure. So you see this different gamma of diameters. This is the diameter we've chosen over the years, and we have spectacular results, I have to say. In fact, I have patients that are out 7, 8 years with a great weight loss, permanent weight loss. Most patients are going to get a little bit of weight regain over the years, but it's around 10 to 20%, and that's usually controllable and very easily controllable with taking care of how you eat and your exercise regimen, etc. But it's not the main struggle that you had over the years with like the big excess weight you needed to lose. So anyways, going back to this slide, what do we do at OCC? We've got a proprietary technique where we anchor the fundus to keep it down. You see how this area now looks like this area? This is the esophagus, and this area is the stomach. The esophagus is that width, and now your stomach, when we do a procedure, is that width. So basically, remember we spoke about this diaphragm that has a hole in it where the esophagus passes through and meets the stomach? Well, this stomach can creep up into the chest. So what we do with this technique is we basically anchor the stomach in order to keep it down below the diaphragm. So that's called the fundic anchoring technique. And you know what else we do? We do the proprietary OCC technique called the double buttress technique. And what do? We microcalibrate, we do a double seal here, and we make it resilient so it lasts a long time. So not only microcalibration produces better, more substantial weight loss, it also creates a double seal right here that makes it even more leak proof. All right, and last but not least, when we see this image, we're seeing this blue tube, and as we remove the tube, you end up with a small diameter. In this case, it's a sleeve, which has like around 80% of the stomach has been removed. Now, people ask me, how much percentage? You never really know, because the stomach is a muscle, and it actually grows accordingly to how much you eat. How big can a stomach get? Well, you're going to watch our YouTube videos that we're going to inflate a stomach and see how big it can really get. It can get as big as a party balloon. Anyway, let's go back to the slides, and last but not least, let's now look at this. Come on, play video. Oh, done. There we go. And right now we're going to go on to our online questions, and I'm going to go into the online question number 1. And the online question is, what qualifies someone for revision surgery? So, for those of you who have had weight loss surgery, don't go on wanting revision surgery before you have an idea of how your surgery works, which is what we just showed you. Number 2, surgery is not the solution to all things. Surgery is a tool. And you guys know at OCC, we're always on top of our patients, calling them up, sending them emails, sending them our online education and follow-up program, these video snippets of 2 to 3 minutes with an education purpose that result in you understanding, and that's the instruction manual for your tool. And your tool is your surgery. So if your surgery is not producing the results that you desire with a program, then we got to look at it. And sometimes it can be several things. Either you've lost the weight and regained it. It's called weight regain. Or you didn't ever actually get to your weight loss goal. And sometimes you did get or didn't get to your weight loss goal, but the problem is undesirable effects like heartburn, like food getting stuck, just symptoms that are not appropriate or have diminished the quality of life. Those are the 3 main reasons why somebody would get a revision surgery. Revision surgeries come in all colors, tastes and forms. Tens of thousands of surgeries are being done each year, and millions of surgeries have been done over the years since this all weight loss surgery trend started. And it's really not a trend. It really is. The trend was obesity and metabolic syndrome, and the only treatment, dramatic treatment that really had dramatic results was weight loss surgery. So, in other words, what I'm trying to say here is that we're seeing a lot of revision surgery. And like I said, sometimes it's very difficult to pinpoint what happened. Sometimes the patient fails the surgery, sometimes the surgery fails the patient, and sometimes it's a combination of both. But at the end of the day, we're glad to say we do have resolutions. So what qualifies someone for revision surgery? Either the surgery didn't get or produce the weight loss it was desired, or there was a weight regain, or it's producing undesirable symptoms. All right, let's go to the next question. And this question is from Emily. If you have already been sleeved and need a revision, is it always a plication surgery, or will they remove more tissue from the stomach? That's a great question, Emily. It's a great question, in fact. So as time has gone by, we have learned over the years that it's not one size fits all. And you're going to get many answers from different sources, especially if you're talking to bariatric surgeons, you might get 10 different answers. But here's the truth of the matter. We are plumbers. Yeah, you heard it here at the light side. Surgeons are people plumbers. What I'm saying with this is that if anybody out there is a plumber or knows about plumbing, it's all about pressures. And it's all about diameters. And that's how not just electricity flows, it's also how liquids flow in plumbing. Same thing happens with our body. We have a very long esophagus, which is a short diameter, and when we modify the stomach to different diameters, we're going to have changes in pressure, changes in pressure inside the system, depending on the diameter and the thickness of the wall. And those are the important things we have to take into account when we do surgery. So, to answer this in review, sometimes, especially, look, I've been doing this for, like I said, almost 25 years, and unfortunately, and take notice of this, people sometimes are looking for the cheapest option for surgery. That's not a good idea. Cheap tires, your life depends on it. Cheap surgery, same thing. And I end up revising these surgeries. We are revision specialists. Like I said, almost 20% of our surgeries are revision. And unfortunately, I have to fix what somebody else screws up. And yes, that patient may have, saved 20%, but now they're going to spend 200% because now I got to fix it. So don't go cheap. And if you have friends, don't let them go cheap. Do your homework, go online, get a reputable center, go to, if you haven't had surgery, go to somebody that's qualified, certified, etc. Anyway, sometimes I see these stomachs that were kind of stapled, but then they got into trouble and they didn't end up stapling. And the biggest problem here is that, remember we were talking about pressures? When we have the pressure thing, and I'm going to show you in my slide, if this is a stomach and we staple this stomach and make it small, looks like a tube and everything's good and well. But what if these surgeries I told you that happen, that are, we call them sloppy sleeves at El Cheapo Center, and you get the free pair of Ginzu knives absolutely free if you act now. All right, let me show you the slide because I haven't shown you the slide. Let's go again. So this is a normal sleeve, but when you go to El Cheapo Center, they get into trouble over here because this is where the vascularity is, and they end up leaving this bump right here. What happens when patient starts eating? Well, this area starts expanding. See? Here's the diaphragm. This is your esophagus up here, right? This is your esophagus. As this part starts expanding, it has less pressure here to push the food down distally. So it acts like a barrier right there, and then patients start getting all these form of symptoms like heartburn, reflux, regurgitation, food coming up, and no weight loss. Well, that's all a problem simply because this area wasn't stapled correctly. The surgery wasn't done correctly. What do? Well, I have to go back in, and once I go back in, the anatomy doesn't look good at all. It looks horrible. It looks like a big bulge like this, so I have to restaple and remove that. Sometimes, as the question asks, do I have to plicate? Plicate means basically just folding, an infolding. Sometimes I do because there's not enough tissue to staple, so what we do is we micro-calibrate using suture material. So hopefully that answered your question, and we are going to go to the next question. Done. There we go. And then let's go to the next question, and this question is from Kim. Do the doctors believe that eventually every lap band will need to be removed, or do some appear to be fine forever? That's a damn good question. Well, anyways, many years ago, I started doing lap bands. I was trained by the guy that developed the technique, Dr. Mitiku Belashev from Belgium, good friend of mine, my mentor, and we did tens of thousands of gastric bands. And good procedure in general, but it's a finicky procedure. When you place a band, a foreign body inside the body, well, it's subject to the forces that the body will produce on that implant. And unfortunately, that area where we place the band is the highest part of the stomach. It's in constant movement. Your heart is beating, your diaphragm is breathing, your stomach is sliding up and down and churning food. So a lot of things can happen. Having said that, in general, it's been a good procedure. It's a restrictive procedure, but there's a lot better procedures now. It's finicky. It's kind of like old TV sets. Yeah, you can watch TV there, but there's now plasmas and new technology. What's happened over the years is that because of the variability of techniques and devices and how they were implanted and how they were followed up with adjustments after, there's been around 30, maybe 40% removal rate of bands. When do you need to remove a band? Well, I'll tell you. You need to remove a band if you have symptoms, undesirable symptom, like I said, if you lost weight and regained weight, or you haven't lost all the weight. That's the same premise, the same fundament in revision surgery. I do have to tell you this, and this is a word of caution. If you have symptoms, even mild symptoms, women, if you have symptoms with a band, don't wait. I've seen women wait 2 years, 3 years with symptoms. which they called mild, which is vomiting every single day, food getting stuck, teary eyes in the table, running to the bathroom, throwing up, etc. Those are hurting your esophagus. And the esophagus is feminine. I say this with the utmost love and respect because a feminine, a female, never forgets, sometimes doesn't forgive, and they're delicate. They should be treated with delicacy. That's the same thing with your esophagus. And women will ride it out. Men are wusses. At the first symptom of something getting stuck, they cry papa, they cry mama, they cry doctor, and they come for help. Women don't. They wait months, sometimes years. If you have a gastric band and have symptoms, immediately get treated. What's the first thing you have to do? Get it released. If you don't know, get it released. The other thing is get a barium swallow. And if not, just call us up and we'll help you out. All right, let's go to the next question. And the next question is, I was sleeved 3/1/2008 at OCC. Best decision ever. I agree with you. My cravings for sugar, soda, junk food was gone. Food intake was very limited. I lost over 65 pounds. Now my cravings are back and have very little, no restriction. I've gained back 40 pounds. Would a revision provide the same results to the original surgery? What other revision options do I have? That's a great question. And I'm going to break it down. See how somebody says we have no cravings and then suddenly I started having cravings. So that my first question to Sonia is, did you just start getting cravings, or was it something happened and you changed your pattern of eating and you started back going into carb eating and then you started getting cravings? See what I mean when I say it's a tool? If you use the tool right and you decarb your life, detox your life, and replenish your gut bacteria, which are 3 principles of OCC support system, you're not going to get this problem. Carbs crave carbs. If you eat sugar, the more processed it is, the more difficult it will be to control. And then what's going to happen? You're going to gain weight. As you gain weight, you produce more insulin and trap more body fat, right? We understand all this, right? Sugar stimulates insulin. If you stimulate insulin, insulin not only gets that sugar and converts it into fat, it traps the fat that you already have. Aha. So, what do? You go crave more processed foods, more sugars, and you produce more insulin. And what happens? You know the drill. And it's a cascaded effect. What happens after? You're 40 pounds heavier. And even though you have a surgery, how did it all start? I'm not saying it might be you, it might not be you. I rarely see, with our techniques, stomach stretching. So the question would be for Sonia, have you noticed you can eat more than your typical intake after the surgery? So the typical intake after the surgery, after you went through your liquid phase and went into the solid phase, you could eat around 20 to 30% of what you would normally be able to eat. Oh, I can only eat 20%. All right, good. 20% of a sandwich, 20% of whatever. All right. If you can eat 50%, you definitely need a touch-up. I'm not going to call it a major surgery, it's a touch-up. If you have these symptoms where you can eat more, it's a good indicator for a revision. But if I'm going to give you restriction and you say, oh no, I can still only eat 20%, then I'm going to ask you, then what are you eating? Because if you can only eat 20%, you should be losing weight. Hope that answers your question, but obviously consult, look us up. You're our OCC patient. You're our patient for life. You're part of the family, so look us up. All right, next question. There we go. And the next question says, this is from Stacy. Is the recovery process the same? Is the cost the same? Kinda and kinda. Yeah. Revision surgery, if it was done by us, we exactly know what we did, so we go in there and it's more or less very straightforward. So it'll take maybe 5-10 minutes more and we can go in there, do what we got to do, go out. And that's why we call them touch-ups, because we know what we did and we know where, once we measure with a barium swallow and look where it grew a little, it's stretched, etc., we can give it a little touch-up and call it a day. If it's a revision surgery coming from somewhere else, different centers produce different techniques and have different results. Some centers actually have, I'm always going to say it, I don't care. If you go cheap, you're going to pay twice. Enough said. And yes, revision surgery may be a little bit more costly depending on what we're going to do. All right, let's go to the next question. And this question is from Kim. When revising a band to something else, what are the key factors to consider in choosing what to revise it to? That's a beautiful question, Kim. I'm all about the best bang for your buck. And when I say this, I'm trying to say, if I'm going to start killing a fly, I'm not going to use a shotgun. I'm going to use a fly swatter. And most of the times, it's going to do the job. Damn, that's a good example. Same thing. Same thing with weight loss surgery. I'm usually going to do the least amount of surgery for the best amount of weight loss. Now, having said that, we already spoke about gastric bands. Gastric band is our #1 revision. Why? Well, because we said they're finicky and they move around, and sometimes they don't produce the results, or sometimes they add bad things to the equation, like stretching of the upper pouch and stretching of your esophagus, a lot of heartburn, reflux, even pneumonias, pulmonary problems because of aspiration, ear infections, all this stuff happening simply because you have a gastric band, in other words, an obstruction. So we go in there, remove the obstruction. Now, common knowledge around the world is going to say, well, you can't have a restriction and convert it to another restriction. I beg to differ, because 99% of the times when I remove a band, I'm going to convert it into a gastric sleeve. Why? Well, because I'm actually releasing the pressure, #1. #2, patients that have bands are familiar with this sense of restriction, but the difference is restriction or obstruction. And that gets lost in translation. Many patients with bands end up with obstructions, and then that's how they control their weight, by eating and then it getting stuck and then throwing up. And that's how they live their lives. No, bad. Restriction is a different thing. Restriction limits your ability to overeat, and you end up eating around 1/3 of your intake. Now, for all those that have bands and are feeling that, or don't feel any restriction at all either, or what would you say if I could offer you eating around 1/3 of your typical intake and you feel full and you lose weight? Hey, you'd love it. So that's why we choose from a band. We remove the whole band, the scar tissue around the band. We pull the stomach down. Remember that hole called the hiatus in the diaphragm? We pull the stomach back down. We remove that hernia. Then once we've got everything prettied up with makeup, then we'll go ahead and do the procedure called the gastric sleeve. And that's called a band revision surgery. When we do that, what we do is we give the patient the ability to eat, but not too much. So they end up losing weight and being happy. That's what we revise them to. Very rarely will I revise them to something more aggressive, but sometimes I have to because of the anatomy. Hope that answers that question. And we're going to go to our last question that we had placed, our friends online had placed, and this is from, from Tina. Would a revision help with a hiatal hernia that's contributing to reflux? Damn, yes it will. If patients have had weight loss surgery and they have severe reflux, that means you have a hernia. And contrary to many surgeons' opinions that they say, well, no, it is. We own our own machine. We have a barium swallow machine, in other words, an x-ray machine. Every time somebody has severe reflux, I give them a barium swallow, and lo and behold, I find a hernia. Remember how I was talking about that diagram where I showed you that as you breathe, you suck in air? Well, you also suck up acid. That's why the stomach is down in the abdomen, where there's positive pressure, and the esophagus is up in the chest. But if that stomach creeps up into the chest, called a hiatal hernia, now you're going to be sucking up acid through the stomach up into the esophagus. It just creates that negative pressure that facilitates the refluxing of acid. And that's why you have severe symptoms. What do? We go back in and fix it. It's also very frequent that around the world you're going to be offered, oh no, you have reflux. If you have, like, let's say, a sleeve, we have to now cut it all and do a bypass. That's not true. Why do another procedure when the problem is something else? If you've experienced weight loss and you're happy with your sleeve, but you just have reflux, we fix the reflux. Why convert it to another procedure? Now, if you have abandoned reflux, that's not called reflux, that's called obstruction. We have to remove the band. We have to release it, and many times we have to remove it. So I'm going to finish off with some questions that we have online, and it's Linda is asking. Well, no, let's start off with, that's a lot of questions. A lot of viewers today. Okay. I'm curious if a person with RSD CRPS can have a band surgery without it spreading the CRPS. All right, band surgeries are not as frequent as they used to be, and living with a band has a very high responsibility because it is a foreign body and it's subject to your body to refuse it, to create immunity against it, etc. So after placing over 10,000 bands, I believe bands have a shelf life, and it's a good option, but there are much better options. So I would ask Melissa to look at the other options, which are extremely similar. I mean, a gastric plication. If you don't want a stapling, just get your stomach folded. And it's a great option with better weight loss and a lot less symptoms. All right, question from Lauren. I'm only 2 years out and only lost 45 pounds. I might have been medication I was on for anxiety. It might have been the medication. All right, yes, it might have. But ultimately, remember, this is a program. So if you had surgery with us, even if you didn't, I don't care. Look us up, send us a text, send us an email, send us a message on the social media platform you're looking and viewing, and we will help you out. Ultimately, because there is this manual that goes with the surgery. Sometimes you may need a touch-up, but sometimes it's just adjusting what you're eating, and it is impressive. By the way, we also have the new MPMD, My Progress MD program, which is a rescue program for those of you that have had weight loss surgery and are saying, I gained 10, 20 pounds during this quarantine. We have the program right for you, so hit Lucia up, our chief nutritionist, and she can help you out. These are dramatic results. We get patients back on track. Remember, carbs crave carbs, fat burns fat. All right, so another question from Janice. Janice, how's it going? This is so helpful. Feel like I'm able to eat more than I should, and it's probably my fault. I drank water too close to meals. Is it possible if you have stretched your sleeve to shrink it back without a revision? Yeah, I just explained that. Really, there's a correlation between what you eat, how you eat it, how slurry the food is. That's why the liquid with the solids. And last but not least, how to reset that pouch. There really is this resetting of the pouch. So that program I was telling you that our nutritionist has, our nutrition teams through My Progress MD, actually helps a ton of patients. There isn't any other resource for patients that have had weight loss surgery that have regained a certain percent of weight. There's some stuff out there, but nothing directed to patients and resetting that pouch. So look us up online, go to My Progress MD, or send Lucia a quick message, and she will help you out. So a question from Linda. Explain why can't we drink while we're eating? Just explained it. And last question, because I'm running out of time. Along with adding the gas, how come you don't remove the gas afterwards? You know what? That's a great idea. Maybe I should, because patients feel really uncomfortable after surgery. Why didn't I think of that? Yeah, we remove the gas. All right, here we go. When we inflate the belly, and in fact, let me show you a surgery. Let me see. Surgery, live surgery going on now. When we inflate the belly, we need a space. So as you can see right here, That's the space you can see at the end of this, all the way to the back, is the liver. And right now, what we're doing is we're suturing the stomach and anchoring the stomach with some ligaments that are in there that are called the omentum. And as we stitch, you can see that there's light inside the belly. Doesn't happen naturally. We have a scope being introduced inside the belly, inside the abdomen, that has a light. It has an optic that transfers that image back into a high definition camera and then into shows it and displays it in a monitor that's right in front of us. And we've got a live 360 version on Facebook and YouTube if you want to check that out, where you can scroll around and actually virtually go into the operating room and look at what we do. So, having said that, in order to lift up the belly, we have to inflate it with some type of gas. The most inert gas, in other words, the least hurtful gas or dangerous gas we can use is CO2, carbon dioxide, the same gas that we breathe out. So that's what we use. Unfortunately, it's not normal to have gas inside your belly. So see how we've distended this whole abdomen, and we can see all the way up into the chest, all the way back there where the liver is being retracted by that metal rod. Well, as the gas expands, it's going to irritate, simply because CO2 is cold, number one. Number two, because it shouldn't be in there. And even though we use half the pressure at OCC, half the pressure that's used globally, the standard is 20 millimeters of mercury, we use 10. And even though our surgeries are 15 to 20 minutes long, on average, sometimes shorter, versus the average being 1 hour, you're exposed to less pressure and less gas. But even though when we finish the surgery, we remove all the gas, patients feel irritation. And then what do? They all talk to each other online and say, use Gas X. Yeah, everybody goes Gas X. But suddenly I've had 2 or 3 really smart patients that say, dude, but isn't the gas outside the intestine? What does Gas X have to do with it? And I told them, aha! Yeah, they're right. Anyways, the placebo effect, I don't care. Bring your Gas X. That's why what we do is we remove all the gas, but the irritation is going to linger. Much like when you're gassy and you feel uncomfortable because you shouldn't be eating all the stuff you were eating and you feel gassy, and the shoulder hurts, same thing. That's how that gas feels. When that gassy feeling that happens after you misbehaved in a weekend of eating chili or whatever, well, it's inside the colon. And that gas that's passing along kind of irritates you and makes you feel uncomfortable. Same thing happens with the gas we use in surgery. And even though we remove it, there's the irritation that has a lingering effect. What can you do to make you feel better? Walk. Walk. Our patients are walking 20 minutes to an hour after surgery, and the more you walk, the better you're going to feel. All right, guys, I'm out of time. I hope you loved this. If you did love this, go ahead and share it. I love teaching. And share your ideas, what ideas you want us to talk about online. Pam does a spectacular job, I have to tell her. She's one of our producers. She does a spectacular job of creating all of these episodes. Very soon, I'm going to be interviewing really hot shots in the medical field. Hot shots that are talking about low carb, high fat, keto, etc. These are like the stars of the show. They're all good friends of mine. I'm very blessed to have them, so I'm going to start inviting them. All right. It's nice to see everybody. Stay safe, and God bless.